We go on to the next talk by Dr. Jayaprasad, PC runs to Toric IOLs.
So traditionally, hello, can you hear me? Yeah. When you have a PC run with a large residual nucleus remaining, how do you proceed? Previously, I always used to extend the wound, or I put a separate scleral incision, do an SICS. Bring the nucleus out into the anterior chamber. This is a pseudo-exfoliation patient. Get the nucleus out and then get it out with Vectis. And then subsequently, I changed over to scaffolding, where once again nucleus is brought into the anterior chamber, do a vitrectomy underneath, so that vitreous is not there in the anterior chamber. Then I inject a 3-piece IOL as a scaffold underneath the nucleus, so that it will stabilize. It will prevent the nucleus from falling back or the bits from falling back into the vitreous during phacoemulsification. But now I have changed. I use the injector cartridge of 3-piece lens from sensor. I inject, whenever I have a piece run with a large nuclear bit remaining, I inject a dispersive OVD under the nucleus at the plane of the capsule. So that will prevent the bits from falling down. Then I go in with the injector filled with OVD once again into the anterior chamber, stuff the cartridge tip with the nuclear bits, whatever is remaining in the anterior chamber, stuff it in, take it out, push it out, and then go back again, fill in with more OVD, but always behind, under the nuclear bits. This is not a very fast process like when you do your emulsification, but this helps. I have done 100+ cases where I have done cataract surgery along with a cartridge. And once you have all the bigger bits removed, you can get out or get all the other small bits outside by visco expression. Now everything, remember that the antechamber is still. There is no fluid flowing. There is nothing pushing these bits into the vitreous. Nothing happens till you push it physically, which also is difficult because you have got a dispersive OVD behind. And now this is the last bit. You are coming out. Always be careful to ensure that there is no vitreous coming into the wound. That bit is a little big, so you go in with your cartridge, go into the anterior chamber and get it out. Now the eye is ready for vitrectomy and ready also for cortex aspiration and a lens into the sulcus. This is another patient, another case. Once again, same situation. PC rent, half of the nucleus is remaining. So you go in, gently get it out into the anterior chamber, always inject dispersive OVD, and then you use the same technique, cartridge and remove. Stuff it into a cartridge which is filled with OVD and remove. No piece goes back into the vitreous. There is no fear of doing emulsification with an open PC. That is all about PC runs with a large nucleus, and this one is where when you catch the capsule, 500 cases, no PC runs, no, you have never caught the PC, and suddenly you are catching the PC, and then you are worried, where is the reflex switch on the foot pedal? Please write it down on the microscope. So you as well as everybody in that OT knows that the reflex switch in the foot pedal is left yaw or the right top or the left top, whatever it is. And my Generation Z OT assistant does this, writes on the Constellation machine, reflex is left yaw. So everyone in the OR knows, and so that you will never be losing that extra time. The third one that I do differently now is LaserX is a laser machine that has been brought out by Kakadia, where he uses laser to mark the axis for toric IOLs. So what we do is, we use our regular 532 nanometer laser, the green laser from the retina department, to mark this. So what we do is, the marking is the same. Remember that the aiming beam is at the center of the slit. So that you center it on the first Purkinje image and then rotate it up gently and then mark the superior one, and then you can go and mark the inferior one. You will get a decent mark which will not go away for 24 hours and then it disappears. That is all that I do differently, so you can still offer laser assisted cataract surgery. Thank you so much.
Thank you. Thank you, JP. Trust JP for coming up with this absolutely out of the box and innovative ideas.
No, regarding the first one, it's when you have a nucleus there and PC rent nucleus, you're putting a vectis. In vectis also you're mechanically removing it. Here also you're mechanically, because underlying there is a vitreous there. You have to tackle the vitreous, then only remove this, no?
We'll always, if you're sure that there is vitreous into the anterior chamber, we'll always do, as you saw when I was doing scaffolding, we'll do a vitrectomy only there. Because it's a big nucleus bit there, it will not drop down in the anterior chamber. It is kept anteriorly by the dispersive OVD, and we'll do a limited vitrectomy, agreed. To introduce a vectis, you have to increase and make a bigger incision. This goes through a 2.8 mm incision, so the wound is not enlarged. And it will never fall down because you have got that dispersive OVD sitting there. Two, there is no fluid flowing through the anterior chamber.
Not fall down. I'm not bothered about it falling down. I'm bothered about the vitreous. So whenever there is a PC rent, I want.
We will always clear the vitreous.
No,
always.
That's right. Whenever there is a PC rent, you do not know whether the vitreous is there in the anterior chamber or not. What I would suggest everybody is to put tricot. Diluted tricot 1:3 or 1:4. Put tricot. Because even God cannot see vitreous in the anterior chamber without tricot. That's my opinion. So tricot, take care of this thing, and then you do all these procedures. Whatever you want to put a cartridge, you want to put a vitreous, whatever it is, doesn't make a difference.
Whenever we have a PCR, it's always practice to use diluted tricot into the anterior chamber. Look for vitreous, cut it off. If it is there in the vitreous, then only do the rest of the procedure, irrespective of the size of the PCR.
JP, all your cases, wherever you have a rent with the piece still there, you use this technique always? Now?
Now, yes.
Okay.
Yes. I always do a vitrectomy if my staining shows that there is a vitreous strand. Always.
Yeah. Very beautiful technique. Thank you.
Regarding the reflex switch, many times, the reflex switch may not work. Please understand that, because otherwise you have to come to zero and then go to the left if you want the reflex. So what I do is I ask my assistant to catch the aspiration line. Either mechanically or with an artery clamp, they'll catch the aspiration if I am catching the posterior capsule.
But in Centurion you can't, those cassette devices, it's difficult.
Yeah.
I have to get up and congratulate JP sir for showing that cartridge technique. Thank you very much. It's an international standard innovation.